and welcome again in this course of occlusion in implant dentistry. As we discussed before, it is very, very important that you understand the fundamentals of occlusion and how it relates to implant dentistry, even if you're just placing implant and even not restoring implant. For dentists who are restoring implant, it is very important to understand the occlusion and its consequences. We looked at some of the consequences in previous videos. And before we understand the fundamentals of occlusion, let's look at the differences between natural teeth and implant, because these are the differences dictates how we are treating implants differently compared to treating some of the natural teeth. So in this table, we are discussing about biological implications. So if you look at the biological connection, you have periodontal ligament around the teeth, whereas in implant, you have direct to bone contact. And there are lots of consequences of these, and we will discuss that further in this course. You have junctional epithelium, whereas you have a junctional epithelium with hemidesmosomes and basal lamina, whereas in implant, you have long junctional epithelium from the top of the gum to the bone level. And that is weak, as we know. So it's very easy to break, and that's why we advise not to probe really hard around the implant, because you could break that junctional epithelium. You have connective tissue. You have 12 types of different fibers around the tooth, which is rich in fibroblasts, whereas you only have 2 groups of fibers around the implants, and there are high in collagen and low in fibroblasts. Biomechanical design is very appropriate when it comes to doing natural teeth. So if you look at the cross-section of the teeth, they are appropriately designed for our load implications. So if you have posterior teeth with 3 roots or 2 roots, big occlusal table, they are appropriate to receive vertical load, whereas the incisors and canines are appropriate placed in the mouth. Whereas if it comes to doing implants, we have standard round-shaped implants most of the time, and that is used to surgically equip us to place implant in the bone. Having said that, there are newer implants coming up with the anatomy of the teeth where you can extract the tooth and place the implant simultaneously. However, the data on these implants are not as good or as much as conventional round implants. You have vascularity, where you have greater vascularity with the teeth, natural teeth. You have a supraperiosteal and periodontal ligament, which supplies really good vascularization to the teeth. Whereas when it comes to doing implant, you only have minor periosteal blood vessels, which are helping ever so slightly, having some vascularity. You have proprioception. You have amazing proprioception when it comes to doing natural teeth because of the periodontal mechanoreceptors, whereas with implant, all the proprioceptions comes from the bone, so proprioceptions rather than proprioceptions from the periodontal ligament. So that is a really main differences, biological differences. The other things you can see is the teeth. You can have more mobility on the teeth than with implant. So implant is less mobility. What are the difference? What is the reason for that? Obviously, you have periodontal ligament in the teeth, as the implant fused to bone. The consequences of that is that when you apply force, teeth can absorb a little bit of force because of the mobility, whereas implant, all the force directly communicates through the prosthesis to the bone. Pain-wise, as we know that you can feel pain in the teeth, and that is protective mechanism, whereas implants you do not feel pain. Occlusal overload, if you have occlusal overload, first of all, teeth moves a little bit, so that reduces the force of the occlusal trauma. You can see wear facets, you can see abtraction, you can see fremitus, attrition, mobility with the teeth, whereas with the implant, you have porcelain fracture, implant fracture, screw fracture, abutment fracture, possible screw loosening or pocketing. So where the consequences of occlusal overload in implant is much more catastrophic than when it comes to doing teeth. And also, it's much more rectifiable. You can rectify at early stage when you know the teeth been overloaded, because it gives you some sort of a sensation. Radiologically, how do you see it? You see a widening of the periodontal ligament. You see radiopacity, thickness of cribriform plate, and that is seen as a PDL widening. Whereas with implant, you see as a crestal bone loss. Interference awareness, you have much higher interference awareness when it comes to doing teeth. So when teeth are interfering and causing pain, you will be able to see it. Having said that, there are plenty of people who have natural normal teeth with interferences. We call it non-working side contacts, and are not aware of it because they are not causing any issues. Whereas in an implant, even if they are overloaded, you won't be able to feel it. And that's why the consequences of interference is much more higher when it comes to doing implants. Non-vertical force are relatively tolerable in where the teeth, where you have a horizontal forces, is relatively tolerable because of the proprioception. Whereas implants, you have much more consequences such as failure of the mechanics or biological failure. You have force-related movement, so you have primary movement, which is of PDL, and then the secondary movement, which is osseous movement. So first, the tooth moves, and then it pushes the bone a little bit when it comes to doing natural teeth. Whereas when you have implant, you only have osseous movement, which is not as much as periodontal movement. So these are the main differences. Now let's look at some of the nitty-gritty, some of the mobility, and what are the tolerances. So if you look at the lateral force, you have all the force are going in the natural teeth where the apical third of the root is. Whereas when it comes to doing implant, all the forces studies have shown is gathered towards the crestal bone. And that's why we see bone loss from the crest downwards. If you look at the mobility, if you look at the lateral movement, the tooth can move up to 56 to 108 micron mobility, and that is helpful when it's come to absorbing force. Whereas the implant mobility, which is mainly comes from bone, is 10 to 50 micron. Apical movement, as we all know that the tooth intrudes, and that could be between 25 to 100 micron, whereas only 3 to 5 micron for implant, mainly because of flex of the bone. Tactile sensitivity, you have very high tactile sensitivity with the natural tooth. When it comes to doing implant, we have very low tactile sensitivity. Sign of overloading, as we discussed, you can see PDL widening, fremitus mobility wear, whereas screw loosening and screw fracture and prosthesis fracture, along with some of the biological consequences, can be seen when it comes to doing overloading. So what these statistics shows us? It shows us that when you have a periodontal ligament in natural teeth and bone to implant contact with implants, you have shock absorber property of periodontal ligament, which is really helpful. Whereas when you come to have implants, you have high impact force. You have longer force duration, which means the force can dissipate much easily when it applies to the tooth, whereas force is straight goes to the implant when you apply force to the implant very impactfully. Distribution of the force around the tooth is much nicely done, whereas implant you have all the force gathered towards the crest, whereas with the tooth the force goes towards the root surface much more evenly. You have tooth mobility, which can be related to the force, again that helps in reducing or dissipating the force, whereas implant is rigid and you don't have that kind of tooth mobility. Same thing as we discussed, when you have a lateral forces, you have the same sort of a scenario. And this you will see again and again with the fremitus. You can feel the fremitus on the teeth, and that helps us assessing the occlusion, whereas you cannot feel the fremitus when it comes to doing implant. And that's why it's very difficult to assess these kind of occlusal loads. Radiographical changes, you can see in the teeth, which is PDL widening. However, when you address the occlusal issue, many times the radiographical changes reduces and it goes, and that means it's reversible. Whereas radiographical changes you see with the implant, which is because of the bone loss, it's irreversible. You cannot grow bone back. Even if you remove the occlusal load, you may be able to prevent it, but you cannot grow back in most of the cases. Now, let's look at some of the design factors. So natural teeth, as we discussed, is designed to take appropriate load in the mouth depending on their position, whereas all the implants, or most of the implants, are designed round cross-section because it facilitates our surgical procedures. If you look at the elastic modulus, it's very similar when it comes to doing natural teeth and the root, whereas implants is 5 to 10 times of that cortical bone. You have diameter related to force magnitude, as we discussed, the diameter of the occlusal table, the number of roots, the diameter of roots, whereas with implants, if you want to place 3 implants for maxillary tooth, it's impossible, and to replicate the roots. So we're placing usually 1 implant for 1 tooth, and that means that the implant is much smaller than normal root, and occlusal table is much more wider. And consequences of these as well we will discuss in further video courses. So when it comes to doing sensory nerve complex, you can see the occlusal trauma induces hyperemia and leads to cold sensitivity, whereas obviously there is no sensitivity of such when it comes to doing implant. You have proprioception, which reduces maximum bite force, because when you bite really hard and if it hurts, your proprioception will tell you not to bite hard. Whereas when we know that with implant, it's 2 to 5 times less when it comes to having any sensation at all. You have less functional force bite because of that proprioception, and as we discussed, you have 4 times more functional bite because you're not aware of how much force you're applying. And this is related to the similar when you see the root canal treated teeth. The studies have shown that root canal treated teeth can bear more pressure, even though they have periodontal ligament around them, just by losing that nerve, that pulp inside the tooth. Now, if you imagine you don't have ligaments, you don't have pulp with implant, so the consequences of that is much, much more than even just being root canal treated teeth. So I hope you understand the differences between the teeth, natural teeth, and implant. What is the occlusal material made up of? So the natural teeth is obviously made up of enamel, which where stress lines appears, abrasions and pits you can see. But what it does is it reduces the impact of the force and it absorbs those force. Whereas the occlusal surfaces of implants are made up of mainly porcelain. Having said that, I am more and more now experimenting with composite material because it has been shown that that is much better at absorbing the forces. Whereas mainly whatever we use at the moment is most porcelain related for single crown and bridges. Yes, we use acrylics many times for full arch cases, and that is better at absorbing forces. Whereas porcelain is much worse. It breaks and it cracks. So I hope this short presentation has helped you in understanding the differences between natural teeth and implant, and why it is very important for us to treat an implant and the load we put on implants and the consequences of that. Because if we put the similar overload on teeth and implant, you will see 2 different consequences. Teeth are much better at tolerating the load, whereas implant is much less likely to tolerate that load easily in a long run. Similarly, I tell the patients the same thing. So if you have plaque around the teeth can, again, healthy teeth can tolerate some amount of plaque easily, whereas with implants, the tolerance level is less because of that junctional epithelium, because the ingress is much easier. Of course, we are coming up with different types of implant. We're coming up platform switching. We're coming up implants such as Prama implant, where the convexity is completely different than normal implants. And that helps us in getting that tissue, and we come up with a tissue level implant where all the bacteria and everything is at the tissue level rather than the bone level where really the rough surface is. So we're coming up with different options to protect and prevent that. However, understanding the differences is very, very key and important. In the next video, we will discuss about some of the fundamentals of occlusion and how to carry out an occlusal assessment. If you would like to have more knowledge, and if you would like to understand much more detail, if you have any questions, then feel free to contact me using social media or my email address. I constantly update some of the resources I provide my students. So if you use this QR code, it will take you to Google Drive, where I upload all the studies, all the materials, all the different documents which may help you in providing treatment with patients who have implants.